and I think will be a exciting, stimulating discussion ahead today. So thank you for attending the first, is this the first, Charles? Charles, the first, right?
Yes,
first.
yes.
The first BMT Symposium, and we hope this will be one of many recurrent symposiums that we will hold, featuring great speakers, and it's mainly to promote discussion on the field of transplantation and how we as a community can work to help improve patient care. So we started off with a provocative title today on Beyond the Perfect Match. And we've got two great speakers, which I will introduce later.
Yes.
Okay. Great start. Okay, welcome everyone. Next slide. Yeah. Okay, so we got an exciting session ahead. So I'll be brief, and then we've got two great speakers ahead. But just to give a bit of context first to everyone, because I know we've got Bronwyn here and friends from Malaysia here as well. So just this one. Okay. So we are the Bone Marrow Donor Programme, and I think just a bit of introduction. We're Singapore's national charity which runs a donor registry, and our vision is we hope to work to provide hope for patients with all blood-related diseases. And our mission, as many of you are familiar, we've been here for 30 years. It's several pronged. We work to build a register of Singapore bone marrow donors. Yeah. But we're very keen as well to see how we can work with our colleagues in the region to build a regional registry. Because I think we're all aware that in terms of donor registries, there's a dearth of donor registry facilities in the region. So, and it's important collectively to see how we can help patients in the region. We're hoping to build a world-class process, and hence that's why we have speakers like Bronwyn here to guide us along the way. And we are always advocates for patients and donors from that. And education is a very key part of what we want to do, hence sessions like this today. And what we want to do is we strive with Charles at the fore is to have a global impact. So particularly focusing around what we can do in this region to help with donor registries. So a bit more onto the talk today. So we know the gold standard for transplantation still remains a perfect 12 out of 12, 10 out of 10 donor, be it a sibling or unrelated donor. We also are aware in this increasingly ethnically diverse world that it's hard sometimes to find a fully matched unrelated donor from there. And this is BMDP registry or data on that. So in this part of the world, for example, we know that if you're Chinese, chances of finding donors is not bad, but it's pretty bad if you're Indian from there. Yeah, and these are challenges. Hence, we have the rise of programs such as Haploidentical programs for related donors, which have emerged in many parts of the world and have become very relevant and helped us increase the number of transplants we can do. But one of the slides, and young people talk a lot about haploidentical related donors. But one of the challenges we have and what we want to do is what if you don't have a related donor? And since if you can do a haploidentical related donor transplant, why can't you do a haploidentical unrelated donor transplant from there? And I think some of the key reasons why we're quite keen to see how we can promote this as well in the Singapore context is a few things particularly related to us as a charity. The cost of a Singapore donor is particularly low. So if you look at it in terms of for Singapore patients, our cost of a donor is around $12,000 for procurement. And as I think you're all aware, in Singapore, if a patient really needs a donor, the BMDP has schemes which will further extend the cost and we can bring it down to zero from there. So, I mean, that's important. So if patients can't have a haplo-related donor, what about a haplo-unrelated donor? And one of the limiting factors we all know is the time to transplant as well. And we know that if you have a haplo-related donor, you can move very quickly. So again, with the BMDP and working with all of you, we're trying to see how we can speed up that process. And, you know, globally, our time's quite good. We can do much better, but it's around 3 months from there. So that's the context there. and why we want to have a good discussion on learning from the haploidentical related donor setting and platform. And I have Professor Koh talk about that, and later we'll have Dr. Bromlin talk about the international experience of mismatched unrelated donors as unrelated donor transplant. So I don't think we need to spend much time talking about Professor Koh. We all know him. I'll just say a few words. I'm into a senior consultant oncology in National University Cancer Institute. He's an associate professor and he's a clinical lead of the adult hematopoietic transplant program in NUH. And I hope I don't offend anyone if I say it, but I think he's de facto one of the fathers of the Haploidentical program in Singapore. So with great delight, Professor Koh.
Thank you, please too high. Anyway, thank you so much, BMDP, for organizing this first event on a transplant, and I'm very honored to be the first speaker for this first event. So my talk is purely on haplo transplant in the context of adult patients. I know there are a couple of pediatricians, but I'm going to show you some of the latest pediatric data. Okay, this is the startup slide that I think most of you have seen it 1,000 times or 1 million times. So as you all know, in any patients who need a transplant, the chances of finding a matched donor from a family is probably about 1/3 or 30%, leaving the rest or remaining 70% having to search for alternative sources that include matched unrelated donor, unrelated cord blood donor, and also haplo donor. So this is the classical, I call it a classical hierarchy of donor search that's been adopted for most of the centers, including us in Singapore. Most of us always prefer the use of a matched sibling donor as our first choice, followed by matched unrelated donor and also cord blood or haplo donor as an alternative option. So haplo transplants, as you all know, offers many advantages. I'm sure you've seen this many times again over other source of donors, including immediate availability. They are always available. All the donors are highly motivated. They are always dying to donate to the family members. We are able to harvest or collect large cell doses, and we can always call them back for further cell top-up for the sake of DLI or stem cell boost. And also increasingly, I'm going to show you some data showing that there's increasing evidence to show that haplotransplant has been shown to be beneficial in terms of slight increase in graft versus leukemia effect. But all these advantages of haplotransplants that has been offset by all the risks, including, the risk of rejection because of the mismatch, increase of GvHD, and also the increased delay in the immune reconstitution because of T cell depletion, and therefore rendering them with increased risk of infections. So you've seen this before. With all the advantages of haplotransplant over the last few decades, there's an increase in the use of haplotransplant in many parts of the world, as shown here in the CIBMTR and also EBMT. And in fact, the latest CIBMTR data shows that haplotransplant has surpassed that of the matched related donor since 2019 to 2020, just before the pandemic. And this is something that we see also in Singapore. This is a registry that we have from NUH showing the increased use of haplotransplant. In fact, we have done more haplotransplant than matched related donor and matched unrelated donor over the last few years. And this slide shows the timeline of some of the important advances in transplantation. And you can see some of the important landmark studies involving the ex vivo T cell depletion for haplotransplant and some of the development of the haplotransplant protocol over the last 30 years. So the increase in use of the haplotransplant is due to the availability of two important platforms. the use of either a ex vivo T cell depletion technique using the magnetic activated cell sorting or MAX, pioneered by a company in Germany called Mutani, and also the in vivo T cell depletion using the high dose cyclophosphamide, as pioneered by the Johns Hopkins group. As that's the topic that Dr. Roman will mention. I will elaborate later in the talk. And that's making use of relying on the selective T cell depletion on the high dose cyclophosphamide on those proliferating alloreactive T cells. So my talk today will focus mainly on haplotransplant using ex vivo T cell depletion. There has been mainly used for GvHD prevention in the context of haplotransplant, although there has been some recent study using this platform for matched sibling donor and also matched unrelated donors. And I'll share with you some of the work that we have been doing over the last 8 years in Singapore, using ex vivo TCR alpha beta depleted graft with upfront memory T cell infusion in the context of haplotransplant. So we can see from here that over the last few decades, we have witnessed some of the important landmark evolution in the graft engineering in the T cell depletion. We have been moving from the CD34 enrichment to pan T cell depletion and towards the more recently selective depletion of the subset of T cells such as alpha beta, TCR alpha beta or CD19 B cell depletion. So the improvement of your understanding of these immunobiologies are important, coupled with the evolution in graft engineering has refined the technique in which we T cell deplete our patient's graft. And now from this graft composition, you can see that we are not only giving the CD34 enriched cells in a graft to the patient, but we are also importantly giving a lot of some important immune effector cells such as NK cells, memory T cells, and also TCR alpha and gamma delta T cells, some regulatory T cells and B cells. So this partial, much more refined T cell depletion selectively removes some of the T cells that we know which causes GvHD, while preserving some of the important immune effector cells that we need for facilitation of engraftment, for graft versus leukemia effect, and also graft versus infection effects. Some important studies that's been published by investigators in Duke, by Benny Chen and Nelson Chow, and also some studies from University of Pittsburgh by Warren Stromchick in their murine models experiment have shown that CD45RA naive T cells causes GvHD, whereas the CD45RO memory T cells preserve some important T cell functions without causing GvHD. So all these observations are important because they provide some basis for us to use this currently employed CD45RA depleted memory T cells add back to the TCR alpha beta depleted graft in a protocol that we've been using for the last 8 years called the Haplo 17 that we started back in 2017, in which we postulated that the infusion or add back strategies of the memory T cells together with the TCR alpha beta depleted stem cells will enhance anti-malignancy effects and also anti-infectious effects. So let's take a look at some of the historical studies that's been published in this area. I'll start off with the CD34 selective stem cell T cell depletion for haplotransplant. So this is a very famous study that all of you are familiar with, the Perugia study, published by Franco Avassa back in 1990s, looking at the cohort of children with heme malignancies. They are all given myeloablative conditioning regimen, and they are all given CD34 enriched stem cells. As you can see, the transplant resulted in a very robust engraftment, but came with a high cost, the cost of high relapse, and also high transplant-related mortality, suggesting that this pan T cell depletion strategies is not ideal by just giving them CD34 stem cells without any immune-mediated T cells, like B cells and also NK cells. Moving forwards, to the newer and more refined studies, there are 3 recent studies that I'd like to share with you using this selective depletion of alpha beta T cell subset for haplo transplant. First, of course, is the Franco Locatelli study from Italy, which has been published almost 10 years ago, and recently they updated their data in their cohort of 213 children with various high-risk acute leukemia. All these young children were given myeloablative transplant regimen in combination with some ATLG or ATG in our setting, which was given distally on approximately on day -5 to day -3 with no post-transplant immunosuppressive therapy. So these strategies, as expected, resulted in very low incidence of acute GvHD and also chronic GvHD. And the relapse rate is about 20% and the low rate of TRM of less than 5%, which is quite expected for our pediatricians. And very favorable overall disease-free and also GAFRS in the range between 65 to 75%. This is the multi-center study published from the same group, was by Alice Bettina, who's currently in Stanford University. She published a multi-center report comparing the outcome of the TCR alpha beta depleted patients versus matched unrelated donor and mismatched unrelated donor. And you can see again, the TCR alpha beta depleted haplo transplant had the fastest engraftment for platelet and neutrophil, and a more rapid immune reconstitution as reflected by CD4 recovery without severe GvHD. You can see the GvHD, severe GvHD is very low, and also very low chronic GvHD. And a safety profile comparable to that of unrelated donor, matched unrelated donor, much lower than that of mismatched unrelated donor, resulting in very favorable survival, comparable to that of matched unrelated donor transplant. Moving to North America, this is the CTC, Pediatric Transplantation Cellular Transplant Consortium, in which 51 pediatric patients received TCR alpha beta depleted graft using the KIR favorable donor. Is based on their KIR mismatch model and high B content, B cell content, following either a myeloablative or reduced toxicity regimen. The outcome is that compared towards against concurrent cohort of CIBMTR patient who had a non-haplo transplant. And again, in this study, the TCR alpha beta had the best disease-free survival, as you can see from the curve here. And the favorable survival was attributed to lowest TRM, lowest acute GvHD, and chronic GvHD, suggesting that these TCR alpha beta depleted strategies abrogate the GvHD without losing the GVL and also possibly graft versus infection effect. Moving to the adult study, there was only one by the German, but in this study, they have combined a series of adult and also pediatric children with hematological and some solid organ tumor. So this is the condition regimen that they have, quite similar to what we have. I'm going to show you, consisting of Taltipa, melphalan, and fludarabine in combination with either a TNI or ATLG, depending on the risk factors. And these patients were all given a short course of immunosuppressive therapy using mycophenolic mofetil. So again, this protocol resulted in very rapid hematopoietic engraftment. However, there was quite significant graft failure, about 15%, around 13%. The cumulative incidence of acute GvHD was quite low. It's only 10%, grade 2 to 4. However, there was quite significant GvHD, chronic GvHD of about 30%. The cumulative incidence of relapse, non-relapse mortality and relapse was comparable to most of the published studies. And overall disease-free survival, disease-free survival, and the GRFS was quite promising. So back in Singapore, since 2017, 3 years before the pandemic, we have started using the haplo transplant protocol, which combined the use of a TCR alpha beta depleted together with upfront memory T cells infusion. We call this Haplo 2017. So this condition regimen, you can see, is quite similar to that of the German published protocol, except we've made some amendment along the way. First, we took off the TNI because of some logistics challenges. Dr. Lindsay is a pioneer in this. He was the one who told us, change the TBI. It's easier, definitely easier. I think that's some advantage because we saw quite a lot of GI toxicity, I think probably because of radiation along the axis. And also, logistically, it's easier to arrange for TBI rather than TNI. And most of the patients were, the first few patients were not given any immunosuppressive therapy, and we saw a lot of CRS and engraftment syndrome, and therefore we decided to amend the protocol and add in a course of immunosuppressant, either CNI or MMUD. I'm sorry what happened to the slide. Okay, on and on. So this is the apheresis product processing that we have in the lab. The apheresis product were collected from a patient donor after 5 days of GCSF injection, and they will process on the day 0 of the transplant, and they are all split into either the 9:1 ratio or 8:2 ratios. The 9:1, the major fraction will be TCR alpha beta depleted. That gives you a graph that contains gamma delta T cells, NK cells, and dendritic cells and B cells. Whereas the minor fractions will be split into small aliquots for us to give upfront memory T cells, and the rest are cryopreserved for further use when we need for DLI or DLI purpose. So similarly, this is a chart that shows the graph composition, the major fractions, and the minor fractions. So the preliminary studies results of this first 100 adult and 7 children were presented at ASH in 2022. And from here, you can see at a median follow-up of about 2 years, the 3-year overall survival was in 70. 5 years at the EFS was 59 and the GRFS was 57%. So I'd like to present the updated data that involves 145 adult patients who were transplanted using this protocol between 2017 to 2023. So these are the baseline characteristics. As you can see from here, most of patients had either acute myeloid or lymphoid or MDS, with a fair number of patients having high-risk disease, and some patients had a high-risk HCT-CI. Most of the patients got their donors graft from either the siblings, followed by children, and followed by parents. And this is the slide that shows the highly efficient performance by our protocol, the alpha, beta, and T cell CD45RA depletion protocol that can be achieved by the mutinous Clinimax system. We have been able to deplete about 5 lots of the 45RA and also TCR alpha beta cells. And most importantly, there was no compromise in the cell dose. We are able to give a median of 6.1 million CD34 to our patients. So we can see from here, the hematopoietic engraftment was quite rapid, with the ANC exceeding 500 per microliter at a median time of 12 days. This is something that you don't see in cord blood transplant, even faster than some of the PTCy that we see. And platelet engraftment was 11 days, even earlier than the platelet, the ANC recovery. Complete chimerism was 100%, achieved in all patients who survived more than 1 month. And that includes 10 patients with the risk factor, all the risk factors for rejection, which include those patients with DSA. All these patients were given a desensitization protocol with plasma exchange, immunoglobulin, rituximab, plus minus Bafico infusion. And 3 patients were also having very high risk of rejection because they had fibrotic marrow. We know that these patients are at risk of graft rejection. In our studies, the acute GvHD of grade 2 to 4 was 31%. You must remember, these are haplo. These are not matched sibling, not matched unrelated donor transplant. And the GvHD of grade 3 and above was only 8%. And most impressively, the chronic GvHD was only about less than 5%. And this is consistent with what the Murai study has shown, that memory T cells are actually steroid responsive. They are what you call, have abortive, like abortion, abortive allo response towards steroids. And the acute GvHD is predominantly grade 2, and you can see that the organ involved in this chart here, with a mixture of gut, skin, and liver. The cumulative incidence of mortality is about 70%, which is something that we see in most of the studies, and the non-relapse mortality was about 7%, sorry. So at a median follow-up of 28 months for all these patients, the 3-year overall survival, event-free survival, and GRFS, it was 67, 62, and also 59 respectively. In a multivariate analysis, the year of transplant, that means when the patient received transplant, was the one important variable that has impact on outcome. As you can see, those patients were transplanted more recently after 2020, which is the pandemic year, had a better survival as compared to those patients who were transplanted before. Of course, we know that these are all due to improved experience, better supporting care, and we are wondering whether there are other factors that impact that. And this is the incidence of viral infections. There were about 44%, 43% at 120 days from CMV, EBV, HPV6, or adenovirus. And we took this opportunity to further analyze 156 patients were seropositive for CMV, and you can see from here the incidence of CMV activation was 33%. And then we also took these opportunities to study the impact of letermovir, because letermovir was only available after maybe around pandemic year 2019 to 2020. So we compared those patients who were given letermovir versus those patients who were not. And you can see again, letermovir, as expected, resulted in a significantly lower incidence of CMV reactivation, which is no surprise, but what the randomized control study has shown. But what we were a little bit surprised was the non-relapse mortality was significantly lower without any relapse, difference in the relapse. And that translated into more favorable overall survival, event-free survival, and this is also shown in multivariate analysis. And the next question you would like to ask is, how is this Haplo TCR alpha beta depleted transplant platform compared to the PD-side that's been used in most of American and North America and also European centers? So we presented this study in ASH about 2 years ago. What we did was we retrospectively reviewed all the patients, contemporary cohort of 70 patients who received PD-side, and applied this thing called propensity score matching, which I learned from YouTube. That's been matched for age, remission status, diagnosis, DRI, and ACTCI, because these are all important variables that have been shown to impact the survival of our patient. And we successfully identified 53 patients, matched patients in each cohort. So, as you can see, there was no significant difference in terms of GvHD grade 2 to 4, grade 3 to 4 between the two cohorts. And as compared to the PD side, the alpha beta depleted cohort was associated with a significantly lower incidence of chronic GvHD and a trend towards lower NRM and also relapse. And collectively, all these differences translated into a significantly improved 3-year overall survival, event-free survival, and most importantly, GRFS in favor of the alpha beta depleted cohort. So we asked another question and asked whether this alpha beta, sorry, you need specs.
No,
Specs.
just No.
Oh, okay, inactive.
Yeah,
Okay.
no worries.
We want to go back in. Okay. We did another analysis to compare the outcome of our patients with alpha beta depleted versus the standard donor transplant with either matched unrelated, or mismatched unrelated. And again, we had the opportunity to present this data during the last ASH. Clearly, this analysis showed no difference in terms of chronic acute GVHD of grade 2 to 4 and grade 3 to 4 among the 4 cohorts. Remarkably, as compared to the matched sibling donor, matched unrelated donor, and mismatched unrelated donor, the alpha beta depleted cohort has the lowest incidence of chronic GVHD. And there was no difference in terms of non-relapse mortality, but there was a significantly lower risk of relapse in favor of alpha beta depleted cohort. There's no there's no difference in overall survival, event-free survival, although there's a trend in favor of the Haplo TCR alpha beta cohort. Again, collectively, all these differences were translated into a more favorable GRFS in favor of TCR alpha beta transplant cohort. Lastly, we did another analysis comparing the outcome of the elderly. What about older patients? Older as in more than 60s. I'm near that. Undergoing alpha beta depleted cohort transplant versus the standard matched unrelated, and mismatched unrelated. Because everybody asked me, why should not offer Haplo transplant for all these elderly patients, which have seen so many. So this is the baseline characteristics. Essentially, they are quite comparable, except some minor differences. All the alpha beta depleted cohort were given RIC. And we broke down into 3 groups: 60 to 64, 65 to 69, and more than 70. And you can see there's no significant difference among the 3 age cohort. And what we are surprised is there's no significant difference in terms of overall survival, event-free survival, but you can see there's a trend, again, in favor of the Haplo, better than the MMUD. And most importantly, GRFS is definitely a winner. The TCR alpha beta has the best in terms of GRFS. In terms of grade 2 to 4, grade 3 to 4 GVHD, there was no difference among the cohort. Again, alpha beta depletion results in the lowest incidence of chronic GVHD. And this again, I think I did not show the GRFS. Okay, I did that, sorry. And there's no difference in the NRM. That's quite a surprise. Everybody say that Haplo transplant will have a higher death, but it's not. And relapse, there's no difference. And in our multivariate analysis, what we show is the donor, that means the use of alpha beta depleted cohort transplant strategies, resulted in the lowest incidence of chronic GVHD and the best GRFS. So with all these emerging data showing Haplo transplant resulting in favorable, equivalent of favorable, more favorable outcome, post-transplant outcome, we anticipate a shift in a paradigm and perhaps a need for a revision of this hierarchy of donor selection. In conclusion, what I've shown you, I tried to convince everybody that our strategies in refining the graft manipulation has fueled the increased use of Haplo transplant, allowed safe engraftment, yielding outcomes comparable or even better than full matched sibling or unrelated donor graft. Our experience with alpha beta T cell depletion, together with the memory T cell infusion, has demonstrated feasibility, safety, and benefit for all adult patients undergoing transplant, Haplo transplant. Further improvement upon this platform by some immunotherapy, harnessing anti-pathogen, anti-malignancy effects of the engineered cells is possible, as majority of patients are mostly off immunosuppressant after transplant. Most of them are not on any form of immunosuppressant, and they are also chronic GVHD free long term. And that result provides very strong rationale for wider adoption of this Haplo approach in future investigations and also practices. So drug and manipulation has come a long way. I will share with this very nice editorial written in Blood last year or 2 years ago. Having overcome multiple obstacles and hurdles, we are inching closer towards a perfect graft. So with that, I'd like to thank all families, patient families, and also caregivers, and of course, acknowledge everybody here. Most of them are here. Our SGH colleague, NUH colleague, Ziyi, Maui, Novena, and also Parkway Cancer Center. And of course, special thanks to the most inspiring person, Professor Wing Leong, and also Dr. Lin, who has been instrumental in the protocol, in this development of this protocol. And of course, all our angels in the ward, nurses, DPM, e-pharmacist nurse, BMT coordinator, MSW, pharmacists, and all the ward doctors. With that, I'd like to thank everybody for attention.
Thank you. Thank you very much for that. So, Liang Q has given a very elegant talk about how, I mean, the Singapore perspective of how I think you can see that I think we're pretty convinced in using ex vivo T cell depletion as a platform for haploidentical transplant. But we recognize as well in part of our discussion, we said that there are limitations in Haplo protocol. Particularly, I think we need a lab setup which can do it, and it does add on cost to the transplants as something that may not be easily replicatable in this region. So hence we've asked Bronwyn to come and give a perspective of how it's done in the rest of the world, including US, which is well, still one of the most advanced countries in the world. Okay, but still quick. But I know Bronwyn from when I was a registrar in King's. Bronwyn did a PhD in immunology and UCL, then was actually a consultant in bone marrow transplantation in the Royal Marsden before becoming the chief medical officer of the Anthony Nolan Research Institute. And in 2014, she moved over the pond to America, where she's a clinical chief scientific director of CIBMTR and professor of medicine at the Medical College of Wisconsin. And she's led many studies on transplant and unrelated donor transplants. So she's going to share us her perspective of transplant data in unrelated donor as well as mismatched unrelated donor transplants with a slightly different platform.
I might stand over here if that's okay, because I think I'll see you better. Okay. Anyway, thank you very much for the nice introduction, and it's such a pleasure to be here. I know some of you for a while, but some of you are becoming new friends, so thank you for the invitation, and it's such a warm welcome. I think this was an excellent session to start this way as well, because getting these really important local data and some of the data that Z showed as well, I think is critical to put things in context. And I think it's interesting. I have a little bit of a different perspective because of moving through different countries. And one of the things that we often don't know is how other people are doing things. And then once you see it in more detail, it's really helpful to understand that. So hopefully I can give you a little bit of a different perspective, and also hopefully some reasons why I think we maybe aren't as close or as far, depending on which way you look at things. So really I'm going to focus on mismatched unrelated donor transplants in this. But, you know, I do want to talk a little bit about this point, about why when everybody hears about mismatched transplants, their brains explode. And it's mostly our own fault, actually, as a community, and especially those of us in the donor registries, which is a lot of people here. And as you heard, I worked in Anthony Nolan for a very long time, because for many years, all the message we always told everybody is, you got a match, it's a perfect match, be the match, one match. You know, everything is geared towards matching, right? And so now we've got to dig ourselves out of this big hole. But the point is that it was correct. The way we used to do transplants, it was clear that the safest type of transplant to have was from an HLA matched, whether related or unrelated. And you see this study here, this is from a long time ago, right? Our good colleague Richard Sidlow, who unfortunately has now died. But you look at these HLA identical siblings, we're doing way, way, way better than anybody else, okay? And here you've got unrelated, mismatched, unmatched, and haplo, and everybody was doing pretty badly, whatever you did. I mean, you've seen those beautiful data from Dr. Koh now, which shows a completely different world. But what I really want to make sure that you think about is all of this was done with calcineurin inhibitor-based transplants, okay? And as we think about this going forward, we need to separate in our minds the donor from the way that we are doing the GVHD prophylaxis in the transplant, okay? So try and think about that all the time. When you're looking at these studies comparing things, are we comparing donors or are we comparing the way the transplants are done? And when we start comparing things that are done in a similar way, I think that the picture changes. But if we focus just really only on unrelated donors, you can see that all this work that we did for years, and everybody knows this very famous paper from Stephanie Lee, which showed that for every HLA locus mismatch, there was a 10% worse outcome. Again, with calcineurin inhibitor now, Z and I, we grew up with Campa. So we know this wasn't exactly the same because we were T-cell depleting. Your experience here, similar ATG, and also in Europe, but in America, it was very much T-cell replete, everybody's transplants. We're giving everybody a lot of GVHD. So, when PT-Psy came along, it was kind of a miracle in America because all of a sudden they didn't get as much GVHD. And actually for the rest of us around the world, we're like, well, obviously, because now suddenly you're doing some sort of T-cell depleting approach, okay? So I'm saying that firstly, PT-Psy is a miracle because it really improved access to transplant for people where you couldn't find a matched donor, either related or unrelated, and you couldn't do these really sort of now standard of care transplants. But it is, please, don't let me have you leave this room thinking that PT-Psy is the answer to everything. I think it was a facilitator, and I think we're now in a situation where we can say, how can we do better? And how can we learn from each other's approaches and maybe combine these things in different ways? And I'm not going to go into this because I think you guys know, the mechanism of PT-Psy. But what I do want to say is, for the rest of most of the talk here is going to focus on the mismatched unrelated donor setting with a little bit of comparative between haplo and mismatched unrelated using this approach. But we went through this thought process. I remember we were at maybe an ASH meeting in San Diego, and we were looking at all of this data from haplo transplant using predominantly PT-Psy, but also all the haplo approaches that were really coming a long way. And we were saying, well, all we're doing here is taking a mismatched donor. So this is making mismatched donors safer. Well, why couldn't we do this with an unrelated mismatched donor? What is the difference? Why would there be a biological difference? And so we approached Jeff Chow. We said, well, how about funding a little study for us to actually look at this in a prospective way? Because everybody's allergic to using mismatched unrelated donors, right? But now everybody loves haplos. So let's do this as a clinical trial so that we can make sure that it's really well done, that everybody, can see that data speak for themselves. And so this was just an 80-patient study, but we thought it was really important to do it at multiple centers because it, obviously something can work very well in one center and then it's hard to translate. So we wanted something translatable. It was only 11 centers, but still that's okay. And we only had 40 patients in each strata now. It was myeloablative or reduced intensity. The reason we did that is we wanted to include as broad a population as we could. It took quite a few years to accrue, actually. You can see that up there, the end of 2016 to the beginning of 2019, as people got more comfortable with doing this. But we tried to include as broad a patient population as possible. We only excluded people with a matched donor, and people could still do haplo transplants in this, but if they didn't have a haplo donor available, because I don't know, I'm really impressed to hear in Singapore everybody has a haplo donor. It's definitely not the case in the US. We find that, you know, in most cases, the reason they don't have a haplo is because the donor isn't well enough to donate, actually, or isn't available, but also DSA. I'd love to talk more about that. That's really a big issue. But we use bone marrow here. A little bit of a problem because we all know where bone marrow has gone. And I'll talk about that more, but we use that because at the time, the haplo transplants were also using bone marrow. Remember this? This started in 2015. So that's the 15. And so we use bone marrow to try and be as safe as possible. And then the PT-Cy, which is standard of 50 milligrams per kilogram, day 3, day 5, and then with sirolimus, day 3 and 4, and sirolimus and macrophenolate. So you won't be surprised that the age is a little bit different for RIC versus MAC. You can see a lot of variability here. This was the first really big surprise that we had. In the US, transplantation is almost entirely for white patients. Usually, if you look at studies, 85 to 90% of the patients getting transplants, allogeneic transplants, are white. So for this study, where we saw almost half were from patients from a racial, ethnically diverse background, and entering on a clinical trial was kind of a remarkable thing for us. We did not expect this. The other thing that was really interesting was that even though most people were most comfortable going for a 7 out of 8 matched donor, we talked about that before, you know, a minimally mismatched, for, you know, some people call it, but actually 40% of the patients got what Z was calling a haplo mismatch. Of course, these aren't haplos. Only 5 patients had a 4 out of 8, but you can see 40% went down as low. And we could talk about this separately. It allowed people to prioritize other factors such as the donor age. We've done plenty of research showing that a younger donor is better. Also now in the haplo setting, we've shown that too. But you can see that people were able to choose a young donor. And in fact, my transplant center, these are the patients, because we prioritized the donor age over the HLA mismatch. So we picked the youngest donor. We didn't care what their match grade was. So this study was powered for a 1-year outcome of overall survival better than 65%. That was what the study powered it at. But you could see that the overall survival here was in excess of that, 72% and 79% at 1 year, with a GRIFs of 55 in the RIC, bad in the MAC, and I'll show you why that was. So we were very encouraged by these results. We also looked at all of the same endpoints that you just saw with Dr. Koh. If you look at the MAC first, what was interesting here is that we did not have any problems with graft failure. So we were worried about that, of course. But then also we saw some quite reasonable neutrophil and platelet recovery if you compared it to haplo PT-Cy. These are definitely longer engraftment than what you were seeing. So, but nevertheless, not something that we were worried about. So that looked okay. Importantly, of course, the graft versus host disease. So it's a little bit complicated, but if you look at the green first, the green is the reduced intensity. So this was using the standard Hopkins protocol in most cases. You know, almost everybody selected that. And you can see that we had 0, 3 to 4 GVH in the RICs, but still obviously 2 to 4. And then we had 0 severe chronic GVH. So very, very encouraging results in the RICs. With the MAC, we still had actually quite a bit of acute GVHD and just about 8 or 9% severe. So it looked okay, but the MAC was definitely a somewhat different population. Because all of these patients also enrolled in the CIBMTR registry, were able to follow the data up long term. So we looked up to 3 years. And actually what was really interesting, I'm interested to hear on the Haplos as well, but we saw no new onset GVHD after 1 year, which is really actually quite interesting to us. The non-relapse mortality has been excellent. You can see here it's 10%, even up to the 3-year mark. And then the reduced intensity relapse was about 30%. That's okay for a REC transplant. We saw a lot of relapse in the MAC, and we think it was probably the patients that were going into this very early study. I'll show you some data after this that looks better on that front. That was definitely a problem, and not surprising you see that growth's not being great. We also looked at infection there. So you can see this is pre-letermovir, and so that's important. But actually our CMV and EBV was quite low. The biggest problems we saw were BK virus, a lot of problems with early BK reactivation, patients in hospital a long time with hemorrhagic cystitis. And then you see a little bit of adeno and HHV6. We collected a lot of infection data. We didn't have any deaths from GVHD, but deaths were from infection, which I think are probably similar from what you've seen. So that was the 1 year survival data, but when we extended it out to the 3 years, you can see that really those 3 years overall survival for the REC of 70% is looking very similar to your Haplo data. MAC was a little bit worse, and obviously the GRIFs was not at all good in the MACs, not surprising there. So at this time, and everybody in the registry here will be very familiar with this, that people just left bone marrow behind. Bone marrow is a pain, right? It's hard to do, you know, no physician likes going and doing it. It's hard to schedule, it's more complicated. It's worse for the donor, no doubt about that. And even in the Haplo world, although the early trials were done with bone marrow, everybody moved across to PBSC without a lot of clinical trials, by the way. But we thought what we should do is actually test this again, do exactly the same study, but do it with PBSC. Because if we really want to convince people that this is the way to do this, firstly, we think you need a clinical trial. Secondly, we think you need something that's easy for people to do and that is actually what people do. So this was the second study. This is called the Access study. It's got 3 strata. We've completely enrolled the 1 and 2. Those were the adult strata. So it was very similar to the previous study in that there was a MAC strata, which people could select. They're not randomized. There was REC, and you could choose between the different REC and MAC conditioning regimens that you'd like to use. I can show you those. But also we hadn't done we hadn't included any pediatric patients on the MUD study, and so we included pediatrics here. And we're actually still enrolling. Pediatric enrollments 28 out of 32. Interestingly, in the US, peds is way ahead of adults in terms of GVH prophylaxis. And so they've been doing much better prophylaxis. They will do similar alpha beta T cell depletion, CD19, and we've got some naive T cell depletion protocols. And so actually people haven't moved as quickly in the pediatric environment to go to the use of mismatched unrelated donors. Also, we had the Abeta study. So there's been a lot of other activity, but there wasn't a lot of this on the adult side. So what I'm going to do is I'm going to show you results from the first RIC and the first MAC with the PBSC approach of full dose PTCI. So a couple of things I just wanted to point out here. Firstly, again, very broad age criteria, different diseases, etc. We restricted the unrelated donors on this to donors 35 years and under. You guys all know that we spent a lot of time looking at this in the unrelated donor world. Younger donors are better. And so we figured when you can go for a mismatched unrelated donor, you can find a donor for every single patient. We modeled it on the registry, and we were able to show that you could find a donor for every single patient, even if you restricted it to under 35. So that's what we did. And the main restriction was we did not allow any patients with DSA on any of these studies. We didn't allow desensitization either. So it'd be great to talk about that. So these now were open at many more centers. So overall, we've opened these over 30 centers, but you can see here 18 centers for the first patients in the MAC cohort. Because it was in the pandemic, some of these products were cryopreserved. We would prefer they were given fresh, but of course, this is the timing. And again, you see this really interesting now, half of the patients are from racial and ethnic diverse backgrounds. For the conditioning regimens, people could pick what they like, and you see FluView and FluTBI are the most common. And then this is, your common high-risk hematological malignancies. Similar to what we saw in the MUD study, probably around about 2/3 of the patients had a 7 out of 8 match, but we've still got those patients getting less. And then here you could see again the donor age was low. And here are the main outcomes. So 1-year survival is what we have at the moment. These data were just presented at Tandem for the first time. So I think you're only the second group seeing them. But, really good 1-year overall survival here, 84%. Can't really argue with that. Hopefully that'll continue. But so the growths here, you remember that the growths we were seeing in the MUD study where we used bone marrow was in the 30s at 1 year, now 48%. So much more similar to your data, which is great. And we've got this acute GVHD 3 to 4 of 8 and the severe chronic of 10%. So very encouraging, very little graft failure. And then the relapse looking a lot better now with probably not as high risk, not as much restriction in the patient selection. Here again, our NRM around the 10%. So very, very reassuring and certainly better than the results than we've had with the bone marrow approach. We are still seeing quite a lot of infections, of course. I mean, infections in transplants are high across the board, and we don't often see that anymore, right? When you do sibling transplants and matched unrelateds, people don't track their infections as much. But so we were doing that a lot, but you can see there's a lot of room for movement here. And I suspect some of your NRM is infection related, right? So this is something we're really focusing on, and I'll mention that to you in a couple of slides' time. So the RIC strata, this is also the first 70 patients from the RIC strata. It's okay, it pops back up. So the only difference here was that we actually restricted the HCTCI to 4 and under, but otherwise all the same characteristics. Very, very similar here in terms of what you see about the breakdown of patient characteristics. And then when you look at the flu side TBI, your classic approach over there. And then flu-mel was really what was being used here in FluView. And then you'll see the diagnoses there again. In the MUD study, we did include lymphomas. Here we are not including lymphomas. So again, these are very similar. I'll tell you what is very interesting here. It's very unusual in a transplant study to see more females than men, right? And so that's something we'll talk about a little bit more, which I think is one of the things with mismatched unrelated donors where you can avoid DSA, because I think that a lot of women who've had previous pregnancies have DSA, don't even get offered transplants, in fact, because they often have very high levels. And so this is somewhere where we're actually seeing that disparity in transplant is also possible to address. So here again, we've got this great 1-year overall survival, and you'll see these outcomes look actually very similar to the MAX. So I won't go through them in detail. We definitely have a bit more graft failure on the RIC. But these patients, we've got the outcomes of them in the paper. Only one of them died, so you've got second transplants in there, and some people who have autologous recovery of cells. Again, the NRM and the relapse looking pretty okay here at the 1-year mark. But again, infections, okay. So this is something that we know that we definitely do need to address. This is my favorite slide, of course, because I personally think that 7 out of 8 is fine. And when people talk about a mismatch unrelated donor, people often in their mind are just thinking of a 7 out of 8. even though they happily go to a haplo related or 4 out of 8. And so, you know, there isn't a lot of data. Of course, this first study is 80 patients. On the access study, we're presenting so far on 145 patients. But what you can see is that in any of these, there's no suggestion that the 7 out of 8 is any different than the 4 to 6 out of 8 in terms of overall survival. Obviously, these are earlier data, but you know, we're going to look at this when we've got the whole cohort together, and everything to date has shown that we should not necessarily worry about going less than 7 out of 8. So I just want to show you a couple of other things that are happening now. We're currently doing the optimized study. The optimized study is actually intended to do the PTCy approach more safely. So one of the things that I just showed you, we see a lot of infection using that high dose of 50 milligrams per kilogram of PTCy 2 days in a row. We see with older patients that they struggle a little bit with it. And we've also seen some cardiac problems with that high dose. So the goal of the optimized study is to reduce the PTCy to half the dose, still days 3 and 4. And actually we did a study run-in where for the patients who were getting a 4 or 5 or a 6 out of 8, we used an intermediate dose, 37.5. We've just finished that safety run-in. We're not allowed to see the data except of course for the, I guess, stopping rules, and it didn't trigger any stopping rules. So we've now gone to everybody getting enrolled in the patient having the lower dose. And you can see where we are, there's no data yet. So hopefully we'll have something to show with us by ASH. So that's currently enrolling. What we're going to do after that is the Accelerate protocol. So we kind of see this as a pipeline of making these mismatched unrelated donor transplants safer and more feasible to do. So the very first study we did, the 15 MMUD, was mostly about safety. Then we moved it to peripheral blood in the access that was mostly about feasibility. And now what we really want to try and do is accelerate these trials, make them much faster. So we're running these as platform studies or umbrella protocols, however you want to look at it. They're going to have, everybody's going to have the backbone that they get randomized against of the PTCy full dose, 50 milligrams, day 3 and 4. And then each individual arm that will be introduced into it will have a novel therapy. So this is to try and improve on the PTCy outcomes. And the first 2 that we'll start with are going to combine abatacept and ruxolitinib with the lower dose PTCy. I'm only showing US data, but this is one study that has just very recently been published. It came out, you know, in the last couple of weeks. It's called the Phylos study from Italy, and I found it very interesting because it's very, very similar patients in number, disease, etc., to the access study that I just showed you. They only did 7 out of 8, but didn't go any lower down. But you can see that actually their overall survival, their growths, many of the other outcomes that they're showing are very, very similar to what I just showed you. So it's very, very encouraging. It shows that this approach is likely to be doable in multiple institutions. So just a little bit of comparative data, similar to what you saw with Dr. Koh, but I do want to say that whenever we show comparative data now, we try and always show it with the same GVH prophylaxis. Because actually, if you look at matched sibling donors, which we always thought was the safest and the best and the lowest GVHD, you can see from the data that they're actually doing worse now than these other more innovative. We've made transplants better, but we've done them better with the newer graft sources, and we forgot about those other things. So we should be doing sibling donor transplants differently. It's not that we shouldn't be doing them. It's that we should be doing them differently. So when we published that first MUD study, we thought we're going to get pushback and people are going to say, well, you know, because this was a clinical trial, you can't really compare it. So we looked in the registry and we actually just looked retrospectively. So these aren't clinical trial comparators, not randomized. Obviously, our data was on a clinical trial, but we just looked in the registry and looked at everybody who had PT-Cy, either having a mismatched MUD or a Haplo. And this was actually in our original JCO paper. And so I think it's stuck. Excellent, thank you. And this showed that, you know, it was just at a 1-year survival that all the overall survival looked approximately the same. And so that just gave us some reassurance. I mean, these are sort of historical transplants now. You know, it's funny when we're saying that more than 4 years ago is kind of historical, but the amount of progress that's been made in the last, or since the 2017 protocol that you started, it's really amazing. But anyway, that gave us some reassurance. These are data that nobody's seen yet. This will be presented at EBMT. I've got some other comparator data that looks at all the donor sources, but for this talk, I just put in the Haplo. And what you can see now, this is kind of interesting, that this is a retrospective study. This is not a clinical trial. And this takes a very modern cohort here, high-risk disease, and we're looking just at the mismatched unrelated and at the Haplo. Obviously, there's a lot more Haplos done over this period, but it's really interesting that you can see that even though overall survival is the same, we actually see a Griff's advantage in the mismatched unrelated donor. And that might be because of the higher chronic GVHD that you do see with PT-Cy, some of that, but also I think we're seeing some lower infections in that setting. So just to finish up, a couple of thoughts here. Firstly, the idea of donor age. So I think overall, when we're looking at these data, we're showing similar outcomes now using PT-Cy with different donor sources. But we know that more recently, the age of the donor is being looked at across all donor sources and not just in the unrelated donor setting. In the past, we always said that the cutoff was around 32 or 35, but our most recent data suggests that age 30 for unrelated donors is the best cutoff. And we also previously showed, I'm sure some of you have seen that it was a linear effect. In other words, every 1 year younger donor did better. And it was quite confusing for transplant centers when you selected, because if you had one donor who was 25 and another one who was 23, and then there was something else like ABO or CMV, you didn't really know what to do. This is much more simple now, where everybody under the age of 30 had less than 1% difference in survival. And so we said that makes sense. Just pick a donor under the age of 30. So the Haplo people in the US have definitely moved to mismatched unrelated donor if they've only got an older Haplo. It's not 30, some centers use 40 and some centers use 50, but there's definitely been a move away from using older parents or older Haplo donors. So this is one of the areas where I think mismatched unrelated donor is growing in the US because of that. The other thing is, I forgot I put this data in, but this is just some data we looked at recently in the US. This isn't published, but you know, we do the center-specific analysis where we look at every center's outcomes at 1 year. And so we looked at the Haplo patients only, and you can see that here, this is the Haplo patients with a donor between 35 to 49 and then over 50. And you can see that the survival is worse when you've got those older donors. So that's very interesting. That's definitely a way that the field is moving a little bit. There are two other things where I think people are also shifting towards mismatched unrelated donors. One is this question of DSA. You sound like you have a really good desensitization technique. There are a few centers in the US that have a nice desensitization method, but many centers find it not that good, and also it really slows you down. I don't know what it's like here in Singapore and in Malaysia, but we have a lot of scheduling issues in the US. So once you've scheduled your apheresis, once you've scheduled your date of transplant, to shift it all around because you're delaying the patient because you need to desensitize, or you're giving a lot more immunosuppression that then results in more infections, all of this sort of stuff, people now just avoid it. If you've got high DSAs, even at Hopkins, they'll go for a mismatch unrelated donor because you can always find a mismatch unrelated donor who doesn't have the HLA that the antibodies are directed towards. The other thing that's really interesting, and I'm sure you guys have seen a lot of these data, is the HLA loss issue, where relapse after transplant has been associated with HLA loss in the haplo setting because you're losing an entire haplotype. Whereas when you've got cord blood, when you've got a mismatch unrelated donor, your mismatches can be on either one of the haplotypes, and so you don't have the same mechanism. This is kind of provocative. I don't know that there's a huge amount of data in the different settings. It's something that Katarina and Luca Vargo and others are looking at in great detail. But it's really interesting because it obviously would help inform what happens after the patient relapses, in particular, if you want to give DLI or a second transplant, where clearly you shouldn't go and use the same one. So I think those are some of the things that has been pushing practice. I'm just showing one or two more slides and then I'll be done. But this is the CIBMTR summary slides. I think it's really interesting to see. If you look at the haplo, you can see that this whole thing is pink. In the US, almost all haplos are done with PT-Cy. In the mismatch unrelated donor setting, this green is calcineurin inhibitor, and the blue actually. And so you can see if you're comparing transplants, you really can't look at a transplant using mismatch unrelated donors until the last 3 or 4 years, because you are comparing a completely different transplant process. Whereas now, look at this, 82%, and it's kind of great that our paper was published right there, and it really pushed the field in the US over to using PT-Cy. But like I said to you, I'm not wedded to PT-Cy. I think we can really do better, or at least standard dose. And you see this drug, abatacept, that's FDA approved, that is starting to be used in this setting too. So we see a lot of interesting stuff coming along. Not a lot of graft manipulation though. If you look at this in the pediatric setting, we see a lot of graft manipulation. And so that's really interesting and different. And so I know that Dr. Koh showed you this last year's. Nobody's seen these yet because this is this year's, which we haven't published yet. But actually what's interesting is, firstly, you do see this matched related HLA identical sibling continues to go down. Makes sense, right? Actually, you see that the haplo, which peaked in 2020, came down a little bit and now is sort of stabilizing. So, but definitely not going up in the same trajectory. Matched unrelated donors continues to grow, by far the most commonly used. And look at this mismatched unrelated donor. Now this is growing, the fastest growing cell source for transplantation in the US. So just to conclude, I really think that PT-Cy was a game changer in the US in particular. Maybe not so much everywhere else where people had already developed good ways to get around the high incidence of GVH. But I think that our idea to study this in a very standard, a very iterative way, going carefully, is a way that we can prove to the community that using this platform, you can really expand the use of mismatch unrelated donor, meaning that really now we should have a donor for absolutely every single patient who needs one, no matter whether they've got DSA or what their family setup is. And the clinical trials are doing this really, really well. But I absolutely don't think that we are there. I don't think we're at a standard of care yet. And what I think is really cool is trying to compare these approaches now to each other, these novel approaches. So I just am going to end with sort of a question slide. And Oh, maybe that slide came off. So go back to the last one. We definitely don't need to deal with all the questions because I think we're gonna have a lot of fruitful things in the Q&A. But that's where I'll finish, and thank you very much, everybody, and really looking forward to a lively.
Very illuminating session. Thanks, Lee, for sharing. Yang, you always do us proud when you present our data. And Bron, it's great to meet you again. After just tandem.
Yeah.
I have some questions, and to save time for everybody, it can be yes, no answers.
No maybes.
Please, okay. So maybe I'll ask the questions first and then 2 comments after that. For the mismatched unrelated donors, you're talking about 8878. So do I presume you completely ignore DP and DQ?
Only a lot of yes, no answers. We completely ignore them, William, in saying that it's an 8 out of 8, 7 out of 8, 6 out of 8. People use them to select the donors. So some people would look at 7 out of 8, 6 out of 8, and then look at DP and select based on that. So people still type for DQ, still type for DP, but they could decide how they wanted to include it. But when you're talking about mismatched, it's not included in the definition. So yes.
Okay, thanks, Ron. I guess it will be good for us if you look at the analysis among those who look at DP, DQ mismatches, they're very important because otherwise we can choose to ignore, we can choose not to ignore. The other question I think you answered when you're matching the 6 out of 8, 5 out of 8, 4 out of 8 ones, do you intentionally look for haplotype? But I guess not, right? Because
No.
you actually encourage 2 haplotype mismatches, maybe, right? Because you have less relapse maybe in that group.
We haven't really deliberately looked at it at all. We haven't guided people how to select that.
Okay, my 3rd question is maybe more a request, maybe. Will MMDP or otherwise be developing a tool for us if we enter the DSAs to help us weed out the potential donors that we can better choose?
Yes.
Oh, great.
They already built one. It's in test with a few sites. And they're hoping that later this year or next year it will be completely ready.
Wonderful. Thanks so much. Final comment. I liked your what you talked about as a transplant is not just one thing, right? You have conditioning regimen, you have donor, you have a post-transplant prophylaxis, you have things like time taken to transplant. You keep searching for that perfect match. It takes a long time, and so I guess it's like a Michelin dish. Got different things that are coming together for that. The perfect graft is one thing, but the perfect conditioning regimen, the perfect post-transplant prophylaxis, the perfect time taken to transplant, and all that comes into the mix. So thank you so much for sharing today. Thank you.
Yeah, thank you, William, for mentioning that point. You know that if William is in the room, you're going to have something about menus or food. So I really like that you made that point talking about the package. We often talk about the transplants as a package, but one of the, I wish I put my slide in about the new selection algorithm because mine looks very different. I'm sure you're not surprised. But actually, last year we published or presented the results from the BMT-CTN 1702 study. This was a multi-center, 50-center study, which was really to understand the donor selection process and to look at the impact that had on the outcomes of transplants. So it was a bit more complicated than that, but essentially what was used was a search prognosis score. So all you need is the HLA type. Every patient who enrolled in the study had their HLA type, and then the NMDP told them if they had a good, an intermediate or a bad search score, meaning how many likely donors you had. And if you had a good search prognosis score, meaning you were very likely to get a matched unrelated donor, then the transplant center just continued and had a matched unrelated donor as their donor type. If you were very unlikely, then the transplant center had to go directly to an alternate donor transplant immediately without doing a lengthy search for a matched unrelated donor. And they could pick Haplo, cord, mismatched unrelated donor, whatever GBH prophylaxis, however they wanted to do it. And the really important thing is that the time to transplant and the rate of getting to transplant was exactly the same. So, in other words, the algorithm should change. We shouldn't have this algorithm that goes first one, then two, then three. But you should look for everything simultaneously, but you should be guided by something sensible like a search prognosis score. And then what I would say is the next step is that we have to think of what prophylaxis we offer, no matter what donor we choose. So.
Sorry, I mean, if I just ask another question, but it's maybe a more provocative question. Given the impact of donor age, should donor registries have an earlier cutoff for initial recruitment for bone marrow donors?
Yes.
Hi, thanks for the talks. Just want to see now, in view of the fact that the donor age of 30 years old and below, would you prioritize, say, someone who is younger but mismatched as a donor versus a full match 35-year-old?
It's a great question. I don't think we fully know the answer to that. You know, we published in JCO last year, Brian Schaefer's paper, where we looked at 7 out of 8s and 8 out of 8s. Unfortunately, in that paper, there weren't enough less than 7 out of 8s to compare. And actually showed the overall survival in the groups was the same. And so that again goes exactly to my comment. All of these transplants were done with PT-Cy. So we know that matched unrelated donor transplants are better as well with PT-Cy. So we might get to a point where that is true. I think at the moment it isn't yet. I think that there isn't enough evidence. But if you have a poor donor search and you only have a few possible matched unrelated donors and they're not available, and you have some mismatched unrelated donors who are young sitting there in front of you, and you are comfortable using the PT-Cy platform, then I don't think you would wait. Thanks, Yvonne.
Alan. Hi, Alan from National University of Singapore, pediatric oncologist. I'm just wondering, Singapore, we like very sexy way of manipulating things. I wonder, Brent, whether now, because the US and the Atlantic, across the Atlantic are very different in approach, would you recommend that young people should conduct mismatched MMUD type of mismatched unrelated donor, but using the way of depletion that he's doing now?
Well, I get to answer this first. I would say yes. Yes, absolutely. I mean, I think that your results are really great. I think they're excellent. And I agree, probably better than PT-Cy at the standard dose. But to me, that's not because it's a haplo. It's because it's such an excellent GVHD prophylaxis. So I would say not only does it need to be tested in mismatched unrelated donors, it should be tested with matched siblings. Did you see those sibling results of yours? They're horrible. You know, I mean, they're not your results, they're everybody's results, right? But when we used to do actually identical siblings, that first graph I showed, you were like, oh, you've got a matched sibling, you're in the best, you will have the best survival, you'll have the least GVHD. Now our patients have to sit in front of us and you want to show them that graph or that outcome? No way. I mean, like, I'm going to choose somebody else for you, but you know what I mean? So I think that we need to be very careful about this now when we're talking to our patients. And be clear with them, yes, if I, if my sister was, I was gonna donate to my sister, I think I'd be wanting to have a better GVHD prophylaxis than just calcineurin inhibitors or something. What do you think?
Agree, totally.
Yeah.
In fact, if cost is not issue, I will probably try this T-cell depleting protocol for matched unrelated and mismatched unrelated. But we are constrained by cost. William?
Yeah, I wonder to what extent the matched sibling results could be related to
Very old matched siblings we have, because a number of our patients are of the older age group.
So I when Yampi always shows this data, because we're trying to get it published, one of the challenges that you put to him is exactly, I think that comparative slide. I don't know what you think, where we show that the ex vivo approach is significantly better than PTCY in that slide, but I guess you could argue that our PTCI experience is quite limited from that. Do you think that was a real reflection of how superior PTCY is, how superior the ex vivo approaches over versus PTCY? So should we just stick with the more sexy, as Alan said, ex vivo approach for all patients with the limitations of logistics and scaling up potentially? Or should we focus on how we can also improve PTCY and what we should do from there?
Well, I mean, I'm always going to say we should do a clinical trial. I mean, we are really bad at that in transplant, right? Everything that seems to be the new, exciting, sexy thing, we just do it. I really commend you on doing the studies. So firstly, I think it's really hard to do the sexy stuff all the time. PTCY is easy. Is it the perfect answer? No, but it's easy. And actually, I can show you some I have plenty of other slides of these summary slides, but now if you look in the US at matched sibling donor transplants and matched unrelated donor transplants, about 65% of them are being done with PTCY. It's a bit different in RIC and MAC because RIC there's clinical trial data and MAC there isn't yet. But so the whole field in the US is shifting that way. And I think the GVHD issue, I'm not sure exactly whether you used NIH severe, so we'd have to compare the exactly how we classified it. Because we're seeing quite low GVH on these protocols. I do worry a little bit that there was a lot of cryopreservation in some of these, this era with our studies, because Steve Devine always jokes that cryopreservation turns peripheral blood stem cells into bone marrow. You get higher relapse, lower GVHD, less engraftment, so it will be interesting to see how that changes. But I actually think we should do a US Singapore study testing these approaches, and we should include children.
Charles Charles is going to fund the study.
He is.
I think it's a great question to answer because I think donning the BMDP hat, where we're trying to look at how we can increase access, not just in Singapore, but in the region. I think one of the challenges we have, I had this discussion with Charles, and because we're looking to fund, and we'll have a talk tomorrow about mismatched donor, is I think we're privileged in Singapore very much, where I think we can push the boundary and look at ex vivo approaches from there. But I think if we want to push donor access in the region, our counterparts in Malaysia, Thailand, other places, I think we have to look at non-ex vivo approaches to really expand the access from there. So it's a question that I think I'm quite keen to look at from there. Because I think, if money is not a problem, I can tell you, I think most of us will say we like the Haplo 2017 approach. But it's finding, as William likely said, I think it's a Michelin disc. But we probably also have to work out how to do a good char kway teow dish.
Yeah. I mean, I do agree with it. I think that having multiple options is probably better than only having a single thing. Because there's always got to be individual patient factors that'll help you decide, right? I mean, there's definitely going to be patients that you don't want to give PTSI. There's going to be some other situations where you might not want to do the graft manipulation or be restricted in that. Just going back to the older age siblings, I think you're right that we've done quite a few studies. We were talking about that a little bit before about trying to look at an older age sibling with a younger age unrelated or haplo donor. But I think part of the problem is there hasn't been a big shift to the type of GVH prophylaxis. I'd be interested to know what you do in the older age sibling. But interestingly, what we're seeing now in the US is that the patients who have an age-identical sibling transplant are much younger than they used to be. The older patients are getting unrelated donor transplants. So it's a real interesting shift away. I don't know if that's similar here or...
I haven't seen that trend yet, but I would not be surprised to see that. One of the problems of haplotransplant for our patients, we have faced DSA, which could be overcome with our desensitization protocol. And also, we believe partly because of the graft that we infused, which has lots of lymphocytes or all the nucleated cells that probably will wipe out all the DSA. So that partly explains why we can overcome all this graft failure in our patient DSA that probably cannot be overcome by PDSI. And the other issues that we face, many of patients are in the middle age group and their parents are too old, and that itself is a challenge because we do not like older parents to be a donor. Whereas the pediatric patients are much more fortunate. All the parents are young, right? Your parents are all in the 30s, 40s, or maybe 30s. So that itself may be a challenge for our patients.
What GVHD prophylaxis do you usually use for the age-identical sibling transplants?
We believe in calcineurin and MMF or MDX, and based on all the randomized study that we have, all the MAC are all given ATG.
Just the MAC, okay, yeah.
Alan. Sorry, William stole my microphone. So the other problem that I have, right, we are talking about younger and younger donors, right? The youngest donor I had was a 1-year-old baby, which we harvested twice to save the brother who has what's called Eldridge syndrome at 3, because the size difference was too big. But that time was, we have no choice, that's the only way we do it. But now, and when we learning from the bad side of United States, we are not allowed to use mobilization regimens from a sibling, let's say below 14 or 12, right? Because they said, oh, we couldn't ask for informed consent because it's too young, right? But I don't know whether with the younger age that you're showing, that maybe the clonal hematopoiesis, the chips, affect the final graft. Why should we therefore not allow a younger sibling to donate stem cell, peripheral blood stem cell, let's say below 14, rather than to use a bone marrow?
I mean, you won't get an argument from me because I agree with you. I think that in the US, I think the cutoff is weight-based, right? For, apheresis. There's been a lot of discussion about consent, and I think it was the American College of Pediatrics that had the commentary in it, Mike Pulsifer and others, we've done work on that. Obviously, you have to have a very robust consenting process. You need to have your donor advocate in place, not just the parents, etc. But outside of that, I think from a physical point of view, if people are confident in doing a procedure, it should be done. I don't have any concern about that myself. Of course, I'm not a pediatrician. And actually in Wisconsin, the rules are really strict. You are allowed to use an HLA-identical sibling who's any age, but you can't use an HLA, a haploidentical sibling if they have a parent, for example. So which isn't good, right? I mean, we know that older parents aren't great. So the rules are very strict and they differ by places too. But so, you know, I don't disagree with you. I think that it's about safety for the donor and then obviously the whole consenting piece. But having strict cutoffs for what you can and can't do is and make a lot of sense.
So, and finally, just a comment that you said, unfortunately, I think National MMDP and others have put in all our minds a perfect match in general, right? And therefore, when actually we were talking about mismatched unrelated donor probably 5-10 years ago in BMDP, it was a no-no because it's that concept is very fixed. We are like the elephant who is tied down to that thing and not change. And I'm glad that the effort is to move away from that, to test that ground. Because to me, it's not logical. Why would a haplo be as good as, or rather be better than a 7 out of 8, for example? But getting the Bone Marrow Donor Programme at that time to cross that line was difficult because other people don't do it, right? And that's the data that I congratulate you all to prove it and to show it systematically.
Yeah, thank you very much. And I totally agree with that. And, you know, I spent most of my career working on this stuff. And so I'm very aware of that problem because it was my fault too. I was definitely part of that kind of push to get away from mismatched unrelated donors, right? But that's why in my mind, it's always so important, the package issue, to think about transplant. It's separate the donor and the GVHD prophylaxis, separate the way you're doing the transplant from who your donor is. And I think we've shown these are safe with good outcomes. So it's great news, right?
Just out of curiosity, in your study, you use sirolimus rather than CNI. Is that a reason?
Yeah, the reason we did sirolimus in the first study was because at Hopkins, they had some data in the lab showing there was a synergy between cyclophosphamide and sirolimus. It hadn't ever been shown in the clinic, but it was, you know, it was shown in the lab. And so we thought we would do that. It was a pain. People hated doing it. You know, the transplant centers didn't like it. And it was harder to manage. And then by then there was some data coming out showing that Siro and Tacro sort of were equivalent. Not that it's been tested, you know, in the randomized sense. Do you use Siro at all?
Rarely, except for patients with renal impairment.
Yeah.
So in a subsequent study, the SRA study, you move away from sirolimus to calcineurin?
Back to Tacro, yeah.
What's that? Just wrap up, just for everyone, just I think there's some questions. Last one's quite contentious. I think I'll skip that. We've covered the first topic. I think the second topic, you don't use matched sibling transplants, do you, in the US?
No.
You don't, yeah, okay. And the third one, I hope we all act in patients' best benefit. We'll ignore the last one. So quick recap, I think going back to the donor selection thing, because I think, as you said, we're all quite wedded to how we practice sometimes, and you know, the donor age thing has come up again and again, but I think many of us quite often don't always practice what we read. So from your point, if you have a fully matched sibling donor who's 50 years old, versus a matched unrelated donor versus who is 30 years old in US, what would you choose?
Thanks.
You're welcome.
Educational.
Yeah. So, as you know, there's a bit of data about this now. In the last 4 or 5 years, there's probably 5 or 6 papers addressing this question that are well done studies, usually looking at patients over the age of 50, so that's important, it's older patients. And then comparing not just to a younger unrelated donor, but also a younger haplo, a younger mismatch. Only one study so far where everybody's using PT-Psi. That's actually just been accepted for publication, but we showed it at EBMT last year. So I'll tell you my high-level summary of the data is that overall survival is actually not different in most studies. It's the differences in relapse control, where relapse is lower with the younger unrelated or the younger haplo. So I think it's a perfect place to do a clinical trial in the high risk, in patients with high risk disease. I think that would really be a fascinating question, but I think it goes back to Yvonne's question again. What we do in my transplant center now is if we've got a patient whose siblings are older than 50, we will look at the other options right away. And that doesn't mean we will definitely do a younger donor that's unrelated, but we will quickly move to that if we see that there's any delays or whatever. If there's a sibling donor sitting right there, they're good to go, you know, they don't have any medical issues, we think that's going to be fine, we may still do that, but we'd be very, very quick to pivot across to something else. We don't do chip on everybody, so we do not look for clonal hematopoiesis or other, monoclonal things in our donors as a rule. How about you?
So what we have done, I mean, this is not in the context of clinical trial. If the patient has a sibling donor that's old, more than 50 or 60, and he has young adult children, I would still offer haplo transplant over unrelated, although I know there'll be a lot of bombs thrown at me.
So I don't think we've got any results, any data in the US showing that haplo is better than a matched unrelated donor or a Haploidentical sibling.
But this is in the context of ex vivo T cell depletion, not the conventional PT-Psi.
Right, and the only real where we've got a lot of data on that is PEDS. Not exactly the same platform, although interestingly, you know, the platform that's is doing very well in the US at the moment is the Orca Bio platform. I don't know whether you guys are aware, it's a little bit of a black box technology. It's different where you can tell exactly what's going on. But it is also a depleting approach then with add-back early after transplant. And they just published their didn't publish. They're going to present their phase 3 at EBMT, but it was a positive study with less GVHD in the experimental arm. So the transplant centers who are participating on that really like it. So as I say, pediatricians are much better at doing these kind of strategies. But with adults, I think it is changing a little where they're getting, where across the board, everybody's trying to improve what they're doing so that all the outcomes are better instead of just being, stuck in the mud.
Another provocative question. So if it's a 60-year-old matched sibling donor, no, you realize it. 60-year-old matched sibling donor, you don't have a haplo, 7 out of 8 30-year-old unrelated donor.
Well, I think at our transplant center, a year ago, we would have definitely done the 60-year-old Haploidentical sibling. Now, that would fall into our category where we would quickly type the other options. And if you had a great unrelated donor, would likely choose the unrelated donor.
It was a mismatch, unrelated donor.
Oh, sure, it doesn't make a difference. Yeah.
Young people?
Yes, agreed.
Okay, great. Our last question.
Francis, I'm a pediatrician from MMUD. Just with all the data with the haplotransplants, and the different factors with age and all, has gender mismatch been, studied or observed, especially mothers to sons or females to males?
Yeah. So that's another thing I've spent my whole career trying to do is tell people to use female donors just as much as male donors, right? The whole world's concept that young men was better was right in the young, but not right in the men. But anyway, that's just a bugbear. No, seriously, there is some data on that in the Haplo setting. Just in the PT side setting, there's a very recent study, which isn't published yet, but that CIBMTR just did, looking at only children, only PTs. No, actually, that's why it's not published, because they expanded it to all GVHD prophylaxis. And essentially what it showed is that the older the donor, the more GVHD. And with mothers, there was more GVHD. And I think that's kind of a similar finding that many have had. So I think that does roll through to the PTSI setting as well. And I'm not sure if you see the same thing or.
We saw some trend. I mean, no, not trend. I don't think we saw any difference in the gender or in the ex vivo T cell depletion protocol, but age does, no, not check. The donor, we saw better outcome among patients who received donor from family, so from children and also from siblings than that of parents.
Okay.
Okay, great. I think, any more questions? No?
Just a comment.
Okay. Closing remarks.
Not really. I mean, just you were talking about the choices and so on. I think, and this is also an appeal. One of the things that affect choice is time to transplant. So if I think a haplo, I can get it quite quickly. Quick availability. I'm not going to worry about the donor flying back from some country or something like that. Then I might take the haplo. But if I have an unrelated donor that is quickly available, prompt response, not going to drop out for any particular reason, and why not?
I'm absolutely going to have to answer that. Because there is a perception in the field that haplos are quicker. And every single piece of published data that I've seen shows that's not true. So I would like somebody to show me data. We all know, of course, when a patient's sitting in front of us, that in some circumstances, it goes quicker. And we all know about some, but in that 1702 BMT-CTN study, which I told you was either matched unrelated versus alternate donor, the time was exactly the same. There was no difference in how quickly, no significant difference, maybe a few days. So I think we need to bear that in mind. Now, this could differ where you do your transplants, right? I would say in the US, what is being done much better now, and in the UK too, this was always a problem when I was there. People didn't type the patient soon enough. They didn't do the search soon enough. But in that 1702 study, we looked at the reasons that patients didn't get to transplant when they said when they were planned. Less than 7% of those were because of a donor issue. In other words, the majority of reasons that a patient didn't get to transplant on the day you wanted them to was for a patient reason. They relapsed, they had an infection, or some sort of logistical issue. So really, I don't believe that in general terms, a haplo is always quicker than an unrelated donor.
I'll just add on to that, then I'll let you rebut again. But I agree with it. I think we can do better. I think in Singapore, I think where families are very close. I think the turnaround to fair say, I think it depends where you are. In William's defense, I do think that mobilizing a family donor is quite fast sometimes in Singapore where we have close-knit families. But again, that being said, I think we are working to shorten the time for donor selection. I think dropout globally is an issue. But again, what Roman has shown is that we fix the platform, and it's not fishing for the perfect unrelated donor, for example. That's part of it as well. And I think hopefully our data has shown that it doesn't have 8/8, 7/8, 6/8. If you're using PTCY or ex vivo depletion protocol, if we're less selective, and we're going to discuss that tomorrow as a community, if we're less selective of the perfect donor, then potentially finding the right donor who's able to step forward quickly may be a game changer as well.
Yeah, so I agree. Ron, I wasn't trying to, but I was trying to make an appeal for, on the registry side. Now that across the board, across the world, for faster response. My own experience is a German donor, US donor. I get the donor quite quickly, and the dropout rate is quite low. But other parts of the world, there are some countries in which you don't hear an echo. So this is kind of a general appeal, for across, especially Asia.
No, definitely understood. And I mean, the US is one of the worst for donor availability, but fortunately has tried to mitigate that with using things like the donor readiness score. I think, and that's a call out to the registries. To me, what the registries can do to really, really help the transplant centers, have as much data as possible listed up front. Have the CMV status always there when you do your initial search. Always have the ABO. Can we have the donor wait? That would be nice. Some sort of readiness score. How recently did this donor interact with the registry? These are the kind of things that can really help you narrow that list down to know, okay, well, actually, in this case, I do have to look more. Or in this case, look, I've got all these great options. This is going to be fine. But I totally agree with you. I think that as a field, we can do better in more upfront information and then targeting those that we really can expedite, right?
That's a great way to end the session. To sum up what Bronwyn last said, the field's changed a lot of exciting, thought-provoking things to think about, but we can always do better. So to thank you, Bronwyn, for making your way all across. You're here in Singapore for a few more days to share all your expertise, and we're gonna milk her for all it's worth. We'll feed her back as well, but William, Michelin star restaurant. And thank you, Yang Q, as always, for sharing your experience as well. So I think it's been a very productive session. Thank you very much. Clinical and network.